Today's topic is the cardio rehabilitation. I am Dr. Mehwish Khan, lecturer, Institute of Physical Therapy and Rehabilitation, Zinazan Medical University. Lastly, we had discussed about the arthritic changes or the arthritic rehabilitation. Now we are going to discuss the cardiac rehabilitation. What is the cardiac rehabilitation? What are the goals? And these are the basically objectives that we will discuss further. Cardiac diseases. Actually, rehabilitation is a treatment process, is a treatment approach. So before starting the treatment or the rehabilitation process or the procedure, we have to discuss some basics of that system related diseases. So the cardiac related diseases or the cardiac diseases, common sign and symptoms. Of course, if there is a disease, so there must be a sign and symptoms. And what are the common sign and symptoms of the cardiovascular disease, that we will going to discuss. Cardiac rehabilitation. What is cardiac rehabilitation, and all aspects of the cardiac rehabilitation we will discuss further. Goals of the cardiac rehabilitation, or the expectations, or what are the mindset of the rehabilitation team that from the patient. Benefit of the program, of course, indications and contraindications. This is again important. Assessment, pre-enrollment workup, or the before taking into the exercise plan. What will be the considerations, or what kind of patients, or with which kind of symptoms we can take patient or enroll patient in the rehabilitation program, or in the exercise therapy, or in the exercise program, right? The next is the program structure. Basically, the rehabilitation program consists on the 4 phases according to the patient's condition: inpatient, outpatient, ambulatory patient. So these are the basics in which, or on the behalf of that, we have divided cardiovascular rehabilitation into the 4 phases. I'll tell you that what are these phases, and what kind of exercises we can perform in, or we can prescribe to these patients. Next is the implementation of the program, how we can implement, and what should be taken under consideration during the implementation of program, and what are the sensitive parts or the most cautious parts that we have to take into consideration while performing the exercise. So let's get started with the cardiovascular disease. That what are the cardiovascular diseases? The heart diseases, or you can say the cardiovascular diseases, clinically diagnosis depends on, or the clinical diseases are the most popular diseases are the atherosclerosis, any blockage, any obstruction, or any block in the coronary arteries, or in the pulmonary arteries, or in any important or essential artery that could lead to the life-threatening situation. The second one is the altered myocardial muscle mechanism. The mechanism of the production of the systole and diastole, or the production of the action potential from the SA node to the AV node, and the whole physiology behind that muscular mechanism, or the action mechanism. So if any alteration in the in the SA node, or in the AV node, or any delay in the signaling of reaching from one point to another point, that alter the atrial contraction to the ventricular contraction, or it increases the ventricular contraction than the atrial contraction, or the vice versa. So due to that, and due to that abnormal mechanism, due to that altered or deviated mechanism, any cardiovascular disease can be occur. Valvular dysfunction, obviously, if the valves are weak, or if there is any regurgitation or the stenosis, it could also lead towards the cardiovascular disease. Arrhythmias, different type of arrhythmias, like the paroxysmal arrhythmia, which is quite stable, in which you can perform the exercise, but later on, if the patient is suffering from the flutters, atrial flutters, or atrial fibrillations, or the ventricular flutters, or ventricular fibrillations. So these are the arrhythmias, again leading towards the worsened condition. So that's why it's also the part of cardiovascular disease. Hypertension, the most leading cause of the cardiovascular disease nowadays is the hypertension. If the blood pressure is so fluctuating, and mostly in the upward direction, or the blood pressure is high, so it also leads to the cardiovascular diseases. Myocardial infarction and the angina, again, these all are the causes, or these all are the reasons that could lead to the cardiovascular diseases, and ultimately patient will present you with some sign and symptoms in the cardiac unit, or in the ICU of the cardiac hospital, or the cardiovascular diseases hospital. So what are the common sign and symptoms with that patient will present you? Number one is the chest pressure. Patient will feel angina. Patient will complain and feel chest pressure and angina. He will complain chest pain, dyspnea, shortness of the breath. Patient will feel lethargic and fatigue because of the weak heart or weak myocardium, which is not able to fulfill the demand of the body. So that's why it have to work so hard. That's why the patient feel lethargic or some fatigue, generalized whole body, because the patient is not taking or not receiving the sufficient amount of the oxygen. So that's why the whole body may be get into fatigued, or patient will complain you about the lethargic or the fatigue, even within bed activities as well. Like if the patient is within a bed or in the bed, and still he or she is complaining to you that I am getting fatigue, or I am feeling the lethargy, or some sort of feeling like that. So it is a common sign. Syncope, also a common sign that patient will complain you some patient will complain, or you can see easily that patient will go into the loss of consciousness secondary to the droppage of the blood flow towards the brain. This is again a common sign. Palpitations, irregular heartbeat. So these are these signs and symptoms that with patient will present you. Cardiac rehabilitation, again, in the last lecture I told you the definition of rehabilitation, that it is a multidisciplinary approach in which the professional from the different background, like the occupational therapist, speech therapist, speech language therapist, physician, nurses, dietitian, nutrition. So these all work together to regain the lost functions of the human body, or simply the functions. So goals of the cardiac rehabilitation. Goals of the cardiac rehabilitation is to reduce the effects of the cardiac diseases. Of course, to prevent from the secondary complication. This is one of the goal of the rehab team, that prevent from the from the prevention from the bed sores if the patient is from the long time and is in the bed. So it is the goal, or it is the expectation again from the rehab team, that he should work on the skin integrity, or prevention of the bed sores or the pressure sores. Limit the risk of the reinfarction of the sudden death. Of course, if there is a emboli in the body, or any like the DVT, so it should be noticed, and it should be noted down, or write it down, or in the file, that there is some sign and symptoms of the DVT or some other emboli. So the medical team or the rehab team should work on it, like giving some heparin or the anticoagulant therapies. Relieve the cardiac symptoms by introducing the exercises, light exercises, when once heart will get started strong, so the cardiac symptoms will also resolve. Retarded or the reverse atherosclerosis by instituting the program for exercise training. Of course, atherosclerosis is a major cause and is the major problem of the cardiac rehabilitation after the blood pressure, of the cardiac diseases, sorry, after the blood pressure. So it should be resolved by some exercises, and by again some medications suggested by the physician. Reintegrate the heart diseases patient into the successful functional status in their families and in the society. Try to maximize his or her activity to meet the level of the physical activity as he or she was before in that. So this is the again goal of the cardiac rehabilitation, that successfully they will try to engage the person into the society, or functional into the society with the maximum functional status. Benefit, what are the benefits? There are myths, and there are the rehabilitation program always uh, go under estimation, or rehabilitation, or the cardiac rehabilitation taken for granted from the years. But from the latest and many researches, it has shown that the patient with the non-complicated myocardial infarction may be hospitalized for as few as for 3 to 5 days. But before that, or before rehabilitation, or when there was no concept of the rehabilitation program, uh, uh, patient had last for months, from weeks to months. But after the rehabilitation program, it reduces as few as 3 to 5 days only. So this is a big achievement, or this is a big benefit, that if we are or the physical rehabilitation team, they are decreasing the burden on the cardiovascular team, or the hospital, or again on the level of, on the government level. So this is a good approach and a largest benefit. Apart from that, offset of the psychological and physiological effects of the bed rest during the hospitalization. Sorry. Of course, yes, when we will mobile the patients as soon as possible, the risk of the bed ridden, or the bed complications, within the bed complications will decrease, and patient will get more healthier and sooner. Enable the patient to return the activities daily living within the limits imposed by their diseases. If there is a demand of any assistive devices or any external support, so go for it, and reduce the chances of the immobility, which is the prime purpose of the rehabilitation team. Reduces the cardiovascular and the total mortality, of course, if we will fight against the comorbidities. So there are reduced chances, or the possibility to possibility of the mortality, or the mortality rate simply will go down, or the graph will go down, if there will be the less comorbidities, and the management of the symptoms as early as possible. Improves the myocardial perfusion. There are some exercises by that we can improve, or simply every exercise can increase or improve the myocardial perfusion, that we can monitor, or we can check by the special test that is called the myocardial perfusion test, in which the CT perfusion or the MI perfusion test has advised to patient. Tests have advised to patient for check the myocardial perfusion, that how much uh, uh, exchange of the blood, or the supply of blood is going into the body, or is how much it is the level is good. There are some indications, like the acute myocardial infarction. Might be you are surprised by listening this, that acute myocardial infarction and the exercise. But yes, if the acute myocardial infarction, the patient now is in a stable condition, so go for the exercises, and try to do exercise, or prescribe exercise, or prefer exercise as soon as possible, right? Because in the early stages, the recovery chances are lot a lot more than the later stages. So there are the 80 to 90% chances, or there are some, in some cases there are 100% chances in the early recovery stages than the later on stages, like in the some neurological disorders, like in the stroke or the GBS or some other neurological disorders. There is a typical uh, uh, a typical recovery period in the early stages, that this is the first initial 3 months are the months of recovery. After that, you can maintain the physical activity, or the state of a patient, or the status of the patient, but the early 3 months are the months of the recovery. So similarly, the early stages of any cardiac diseases, if a patient is in the stable condition, so go for the early exercises because it's the time of recovery in the greater extent. Coronary artery bypass grafting, if the cabbage has done, so you can also do exercise or plan exercise for that or prescribe exercise. Angioplasty with or without stenting is also indicated for the exercise. Any valvular surgery, any heart transplantation surgery, or the great vessel surgery, congestive heart failure, chronic stable angina, but stable angina. The emphasis is on stability. So stable angina or the angina pectoris is also indicated for the exercises. Means all these conditions are indicated for exercises. Patients of these all with these all conditions can improve, can achieve the maximum level of maximum level of physical activity by doing some exercises or by prescribing the rehabilitation program. So there, on the other hand, we have some contraindications as well, in which we are totally or we are absolutely contraindicated. Any kind of exercise. Number one is the unstable angina. Yes, of course, unstable angina in which the vitals are very fluctuating. So in this condition, you are not supposed to do any exercise. Uncontrolled arrhythmias or the AV blockage, of course, like I told you earlier, the flutters, fibrillations. So in these conditions, you cannot, or simply the paroxysmal arrhythmia. But if it is uncontrolled, you are not going to perform any exercise. It could be dangerous. It could lead to the death or some other chances of death, or you can say any heavy amount of damage. Resting systolic blood pressure, if it is a greater than 200 and the diastolic pressure greater than 100, but is in the resting. 200 greater than 200 systolic blood pressure greater than 200 in the resting, and the diastolic blood pressure greater than 100 millimeter of mercury in the resting, which is too much blood pressure. So that means the heart is so weak for the demand of to complete the demand of the body. It is working so hard. If we will do exercise with that patient, that means that we are going to more burdenize the heart or the myocardium, and it could lead to the death as well. So that's why it is again contraindicated for the patient if the resting heart rate is between 200 and 100 as the systolic and diastolic. And recent embolism, of course, embolism, pulmonary embolism is very common, or the DVT embolism. I mean, from the DVT, if any lodge is dislodging the blockage or any dislodging material go into the embolism, into the pulmonary vessels, or into the any narrow arteries or any narrow vessels that can also do the blockage, and can cause the severe damage. That's why if there is a sign, or if there is any reported embolism in your file, and if you have any history, or if you have any written report on the embolism, so do not go for the exercise, right? Moderate to the severe aortic stenosis, any valvular dysfunction or the aortic stenosis, this is again the risk factor, or is the contraindicated. Acute systemic illness or the fever, orthopedic problems, that would prohibited exercises. Poorly controlled hypertension, significant emotional stress or the psychosis, if the patient is unwilling to do exercise, or if the patient is so uncooperative and simply he or she is not understanding what you are saying. So for such patients, again the exercises contraindicated. Core components. What will be the process of the rehabilitation? Initially start from the patient assessment, then nutritional counseling, weight management, blood pressure management, of course, lipid management by controlling some diet, Diabetes management, if the patient is diabetic too, so check their insulin level, or as well as the glucose tolerance test. Tobacco cessation, if the patient is on the smoking or any kind of tobacco, so just omit it out or ask patient to stop taking tobacco or smoking. Psychosocial management, exercise training, and last one is the physical activity counseling. So these are the core components. Any physical or any rehabilitation team will go one by one to progress in the progression to achieve the maximum result. Reduction risk factors, and the risk factors: blood lipids, significant reduction of the total cholesterol or the LDL, and the triglyceride lipid levels should be controlled or within should be in the limited range, and increase in the HDL cholesterol with the training. Of course, this is happening with the exercise. I'm not going into too much detail of it, but the essence of this, that blood lipids should be controlled. Hypertension should be controlled as well. Regular exercise, because we are talking about the rehabilitation, so that means we are talking about the exercises. So hypertension can be controlled by some medication as well, but our focus is exercise, or the exercises. So regular exercise, of any kind of exercise, light exercise or heavy exercise, which burdenize the heart, depend on what kind of exercise you are prescribing. It is going to increase or maintain the arteries elasticity or the flexibility, which also help to manage or maintain the hypertension or the control of the hypertension. If your arterial or the vascular wall is weak, and sudden small increase in the hypertension can also break the vessel wall or cause the hemorrhage, which leads to the stroke or any other disease or any other problem. So it is important to maintain the elasticity of the arteries wall or the vascular wall, and exercises are going to help us in maintaining this flexibility. This ensure good blood flow and the normal blood pressure. Yes, because some up and down exercises or some light and heavy exercises fluctuate your blood pressure, and your body regulates and maintain and try to maintain that up and down blood pressure. And in this way, you and we are going to train the body that how to manage the blood pressure in heavy tasks or in heavy ADLs. So patient will ultimately feel comfortable in performing these activities. Consistent long-term exercises can result in at least 10 to 20 mmHg, millimeter of mercury, decreases in both resting and exercise blood pressure of the hypertension. That is the thing, or that is the from this sentence we are getting idea that by doing exercise, our vessels and our cardiovascular system typically, or the whole, is going to strengthen. That's why with the every exercise or with the regular exercises every day, on the basis of on daily basis or on the weekly basis or in the twice day basis, we are going to manage our blood pressure by 10 to 20 millimeter of mercury in the decreased manner. So the glucose intolerance, these patients can also suffer with the glucose intolerance. That means the lower serum insulin level after the training because of the increase in the insulin sensitivity at the cellular level. This sensitivity also has noticed in these patients. So decrease the serum triglyceride and body fat levels by some exercises, and reduce the body fat by some exercises, as well as by some dietary control, and by some again, dietitian is or the nutritionist is also present in your team, asked to control the triglyceride levels or the fat levels or the this insulin or the glucose intolerance level. So by their expertise, by his or her expertise, he or she can manage this problem of the intolerance. Cardiovascular examination. Now the cardiovascular examination will start from the medical record or the medical record review. If the patient is in a hospital, if the patient still is in a hospital, and that means the all record has maintained and has been prepared by the emergency staff and ultimately in the ICU staff. So the physical therapist or any person of the team, if he is going to examine the patient, so first review deeply and thoroughly the medical record, that what kind of symptoms patient is presenting, and some other comorbidities and some other problems. So patient record or the patient's medical record is important to review. Now the second step is the patient history. For that you have to do some interview or just plan a little interview session with the patient. That also increase the after the taking history, there is another benefit of a patient interview, that it helps to build the trust or the communication level between the patient and the physician or the therapist. So the patient history, the past medical history, present history, any family history, drug history. So these all histories or the kind of histories are very important uh, for the any person who is in the team, or who is the part of team. Now the next one is the vital signs. Check the heart rate, rhythm, shortness of breath, blood pressure, orthostatic hypotension. Orthostatic hypotension is the hypertension which sudden droppage of the blood pressure or the BP while in the change of the position. How I'm going to explain? For example, if the patient is in a bed lying position, and in the rehabilitation program, we are going to make him or her sit. So from the lying to the sitting, there is a postural change, and due to the postural change, blood pressure will go sudden down, or the hypotension will occur. So such type of exercise, blood pressure that will go down, go low or the down with the postural change, because patient is in a bed from the long period of time, and has no power or has no that fluctuation to manage quickly with the posture or with the positional change. That type of hypotension is known as the orthostatic hypotension. So the vital signs like the hypertension, rhythm, or the shortness of breath, blood pressure, orthostatic hypotension, check all these, review all these things before starting the exercise, because if the patient has any instability in these signs, so that means you have to be cautious, or you have to be careful performing exercise, or maybe you have to omit out some vigorous exercise, or some exercises that you have in your mind for the prescription purpose. Okay, now the next is the observation, inspection, and palpation. These are again the important things. You have to be look patient thoroughly. That You have to look patient thoroughly, like if any skin irritation, skin color changes, or simply any discoloration of the skin, or any visible deformity, or if any swelling, edema. So if there is a problem, so you have to observe for that. And the next is the inspection. Inspect and palpate as well if there is some heaviness in the chest, or if any area of the body. So you have to inspect and palpate. Auscultate as well, listen the heart sounds, chest sounds. If there is a abnormal heart sound, S1 and S2, so there is no need to be worried. If there is cardiac murmur or the abnormal heart sounds, then you should notice and you should work on it, or at least record it down in the file, that this is the problem I have noticed in the patient. So these are the cardiovascular, the quick cardiovascular examination, uh, or as well as you can see the EKG or the ECG or some ABGs as well, that if there is any blood pressure, any what is the saturation of the oxygen, or if there is less oxygen saturation, then the symptoms, signs of the cyanosis, bluish of the bluish color of the lips, hands, fingers. So just observe all these changes or some signs as well. Tests and measures, like the ECG and the EKG, you have to check the electrocardiogram. By that you can see many things like the heart rate, pulse, heart rate actually, the heart rates, ST segment elevation, and ST segment depression is also the important in monitoring through the ECG or the EKG. If the ST, this is the common thing, that if the ST segment is elevated, there is an infarction, and if there is a ST segment is depressed, that means there is a ischemia. And infarction can be diagnosed or can be checked by the ST segment elevation and the ST segment depressed. So closely observe and closely see that if there is a ST segment elevation or the ST segment depression, means the myocardial infarction or the ischemia. ETT is basically the exercise tolerance test. It is a test that you can perform by doing some exercise, or simply it is a treadmill test. What we do in this, that we ask the patient to walk on the treadmill, and there is a monitor that is attached with the treadmill, that monitors all the vitals as well as the heart perfusion and heart activity, its tolerance level within the limit range. For example, if we are going to prescribe any patient this test, and while performing this test, patient can perform this walking pattern within the 3 to 5 minutes without exaggerating the symptoms, or without complaining, or without any discomfort. So that means the ETT test is negative, means positive. The ETT test is positive, that means the patient can tolerate the exercise within the limit or within the range. So we can now, this is the indication that we can now perform some heavier exercises. So ETT test is also important to monitor or to record the tolerance power of the heart or the cardiovascular system. Cardiovascular rehabilitation, as I told you earlier, I think I do not need to repeat it again. Team consists on the, as I told you earlier, nurses, exercise physiologist, cardiologist, physiatrist, physical PT means the physical therapist, OT means the occupational therapist, dietitians, psychologist, and the endocrinologist. Outcomes. What will be the outcome of or the expected outcomes of the cardiac rehabilitation? Smoking cessation, number one thing, control of the lipid management. These all are the repetitions. So these are the expectations as well as the objectives of the cardiac rehab. So I think I do not have to need to repeat it again. So then now the cardiac rehabilitation program. Cardiac rehabilitation program is consists on the 4 phases: the phase 1, phase 2, 3, and phase 4. Phase 1 is the inpatient or the hospital-based program within the 24 hours to 48 hours after the admission until the discharge, right? So what is the phase 1? When the patient is entered into the hospital, and if there is any procedure like cabbage or any angiography, angioplasty or anything, any great vessel surgery. So after performing the surgery within the 24 hours to 48 hours, as a patient get stable, so this is the responsibility of the rehabilitation team to start some exercises. So early exercises or the early treatment plan or the early rehabilitation is considered as the phase 1, means within the hospital or within the room until the discharge. After the discharge, there will start phase 2 and phase 3, means this is the phase is that start from the home to the community. And the last one is the phase 4, that is the ambulatory program or the ambulatory exercise rehabilitation, which means that now the patient is in the community and patient is able to walk and ambulate and perform vigorous exercises and can easily walk and go outside. So this is the phase 4. Phase 1 will again start from the 24 to 48 hours after the surgery or after the stabilization until the discharge of the from the hospital. Phase 2 and phase 3 will start from the first 2 weeks post event or after the discharge till the 12 weeks or the 1 year, up to the 1 year. 12 weeks or up to the 1 year means the total 36 sessions generally required for the completion of the phase 2 and phase 3 is a supervised program, is in which the therapist or the rehabilitation team will check and will the patient will be on follow up. So that's why it is called the supervised program. Now the phase 4 is the ambulatory phase, or the almost about or near to the normal phase, means in which the patient now is unsupervised. Patient just now you have teach many exercises to the patient, and now patient is able to perform independent exercise or independent activities without any supervision. So this is the phase 4. Now we are going to describe one by one. Phase 1. Okay ji. So phase 1 start from the activities. I am going to just describe the activities. So phase 1 start from the sitting to the standing to the ambulation. Sitting, or before that there is a step, or there is a point, or there is a stage of the activities in the phase 1. This is the within the bed activity or within the bed mobility. Within the bed mobility, what does I mean by the within the bed mobility? That if the patient is in a supine position, start the exercise or start the positional change, like from the supine to the side line, from the one side line to the other side line on the opposite side, and from now if the patient is expert and patient is not feeling any discomfort in the rolling or in the side lying from the left to the right and from the right to the left, now try to make the patient sit within the bed, but within the bed, from the lying to the long sitting, from the long sitting to the short sitting. These are the various types of positions that a therapist or the student of any physical therapy know very well, that what I am talking about. So this is the within mobility or within the bed mobility or within the bed exercises, from the supine line to the side line, from one side line to another or the opposite side line, then from the if the patient is expert in that, from the now from move to the other step, and which is from the supine line to the long sitting. And like we usually watch the TV, in the long sitting position, the lower limb is straight and the trunk is bent. So this is the long sitting. And from the long sitting to the short sitting, this is the within the bed activities. And now within the bed activities to the sitting like the chair sitting. And from now, if the patient is expert in the from the positional change from the lying to the chair sitting, now move towards the standing, from like initially with the help of the walker, and then without walker, or it depends on completely depends on the patient's recovery stage or state, or the disease state. and the nutritional intake. So these are all the factors that contribute to the level of the physical activity or the type of exercise that we will prescribe. But this is the simple pattern, that from the bed mobility to the sitting, and from the sitting to the standing, and obviously from the standing to the ambulation. 5 to 10 minutes start from the from the least, like the 5 to 10 minutes, or the 2 to 4 times a day. 2 to 4 times a day. Small sessions, 5 to 10 minute session only, but do the multiple sessions from the 2 to 4 times a day. Ideals, if try to ask patient try to eat by his or herself, toileting or any other within the room activities or the ideals. So stair climbing, upper body exercise, upper body strengthening is very important, because might be the person will go on the wheelchair, or from the wheelchair to the walker. So upper limb strength is needed for that. So upper limb or upper body exercises, trunk exercises, disease education, management of the risk factor. These all are the parts of the phase 1 of the rehabilitation or the cardiac rehabilitation. So this is the complete picture of the phase 1. You can see this from the bed mobility, or from the within the bed mobility exercises. Within the bed mobility exercises, this is the patient. Patient is in ICU, and after positional change, we can as well build the strength in the upper limb by doing this kind of exercise, or this is the TheraBand exercise. What this therapist, or what she is doing, that she is pulling, or she is asking the patient that pull this TheraBand away as possible as you can do. This is the bed, within the bed exercises. You can do a lot of exercises within the bed. After that, upper limb, start with the lower limb exercise, and the train patient to go into the sitting, from the lying to the sitting. And these are the special type of beds that you can see in the or you will find in the rehabilitation area or the rehabilitation center. So these special type of beds for the exercise or the treatment is also known as the treatment beds, that are what in this picture, what these two person are going to do, that the lady is lifting the both upper limbs up, and trying to touch the hand and then go down. Will try to touch the hand and then will go down. So these are the lower limb exercise, and by maintaining the upper limb posture and the long sitting. So this is the some vigorous exercise or some heavy exercise than this one. So there are again number of exercises, or number of tricks and number of modified exercises that we perform, that which is completely depend on the therapist and patient, capability of the patient, and therapist design, that my patient is able to go into this exercise, so I have to do that. So third point, after the upper and lower limb strength, or the if the therapist or the any rehab team think that now the patient is able to stand or the sit, so initially go with the sitting, with the high under observation, and then go to the ambulation or the walking. But again, these all are the phase 1 type of exercises, means within the hospital exercises. This is from the early 24 hours to 48 hours till the end of the discharge, or till the discharge plan. So these all are the in hospital exercises, or in hospital plan, or the phase 1. So you can perform, or you can ask any team member to perform these exercises in the phase 1. Okay, so in the phase 1 there are some levels of the exercises or some level of the rehab. Level 1 to level 5. Level 1 is the bed rest or the bed exercises, like I told you in this is the bed exercise, or this is also known as the level 1. Level 2, from the sitting limited room ambulation, means from now we are progressing from this to this and from this to this, means the sitting limited room, sitting and ambulation but within the room. This is the level 2 of the exercises. If we are achieving our targets, that means we are moving in forward, or we are progressing. So always try some small goals or some little goals to which are achievable and which are practical, so the motivation will be remain intact with you and with patient as well. So the level 1 essential or essentially bed rest or within the bed mobility or within the bed exercise. Level 2, from the sitting to the limited room ambulation but within the room, not go within the room exercises or the room ambulation. No, do not go outside the room or in the corridors or some other areas of the hospital. Now the level 3 is the room limited hall ambulation, means from the room to the hall. Now you can carry patient with you and with some assistive devices, with the help of some assistive devices into the hall as well. So from room, now go out into the or to the hall. Level 4, progressive hall ambulation. Now there is no room exercise, now it's straightforward hall ambulation. Now always try to take patient along with you with some assistant or some assistance if there is needed to the hall. So try to exercise 3 to 4 rounds of the whole hall, which is again it depends on the length or the area and that how much it is long. So 3 to 4 at least round should be needed for the hall ambulation. Level 5, progressive hall ambulation. Again, what is the difference between the 4 and level 5? Level 4 means 3 to 5 rounds, and in level 5 more than 5 rounds of whole hall with the assistive devices or with the support of the therapist. In the level 4, more assistive devices or the external help is needed either by therapist or by some assistant. But in the 5, now the support is limited. Now the support will be limited, and patient will feel more confidence and will be more independent. So level 4 and level 5 are the hall ambulations, because after that hall phase 2 will start. So within phase 1, 4 and 5 there is a little bit difference of the support, and as well as the number of walks or the laps that you will ask patient to perform. Now the phase 2 and phase 3. Phase 2 basically is the home exercises, and 3 is the maintenance of that exercises. Phase 2 start from the 1 to 2 weeks post event, lasting up to the 12 weeks or 30 week session. This is compulsory and this is gold standard in everywhere in the world. This has followed 36 sessions and 12 weeks almost. So the medical supervision, EKG monitoring during exercise. Okay, all the time this is mandatory that before starting any exercise at any stage or at any level, you have to check all the basics, like the testings, reports, or medications, any alteration in medications or in the usage or dosage or vitals. So you have to review all the one by one. It's mandatory because you are dealing with the cardiac person or with the cardiac disease person, so it's mandatory to check all the before every exercise, before every session of the exercise. Not in the day, means if your patient is in follow-up stage, so you have to check and you have to take some small history before again performing the exercise, either in the supervision or without the supervision. Phase 2 and phase 3 types of exercises in the phase 2 and phase 3 are the breathing exercises, stretching exercises, small resisted exercises, and ambulatory exercises, of course. Breathing exercises, what are the breathing exercises? How you can perform the breathing exercises? Simply ask patient to be in a straight position, like in a standing or in a sitting. You can perform in both standing or in a sitting. By adapting the neutral position or the natural posture, means without deviation here, without deviation of the trunk or any body part here and there. So first of all, ask the patient to maintain the natural or the normal position or the posture. Now what patient will going to do, that ask the patient or instruct or teach the patient that take deep breath from the nose. Take deep breath from the nose, that your belly or your stomach go out in this manner, that you feel that your stomach or your belly is going out, right? Or is after that, after intaking of the exercise, after taking the breathing in, or after the taking air inside your lungs, now ask the patient to hold the breath or hold the air inside your lung for the few seconds, either 5 seconds, or initially start from the 2 seconds, and from the 2 seconds move towards the 5 seconds. So from the 2 seconds to 5 seconds hold. Now instruct to the patient that blow out the air from mouth, like you are simply blow out the air from the mouth, like doing round of making your mouth round or lips round. Now this is the technique of the breathing exercises. Again, step by step, take the breathe in from the nose and deep breathe. Deep is like your belly or your stomach, you feel that your stomach is going out, right? After breathing, now hold the breath for the 2 to 5 seconds. After the holding, now blow out the air from the mouth by making your lips round, or by making your mouth round, but slowly and very slowly, not like once, like blow all the air at once, but just slowly, like you are blowing out the any ball or any piece of paper. Teach the patient breathing exercises as well as the stretching exercises. Small stretching exercises. I have already discussed in my last lecture as well. But the stretching exercises of the upper limb and lower limb. Stretch your whole body. Stretch your upper limbs. Stretch your lower limbs. In the flexion, in extension, and different movement. So that also improve your blood circulation, and also carry your metabolic waste, and ultimately that improves your fitness and the general health. Small resisted exercises. Because now we have target to build the strength, and we have to increase or improve the strength of the muscle. We have to build the muscles in terms of the strength, power, endurance, energy. So resisted exercises are the best exercises to develop all these. So ask the patient or teach the patient to do the resisted exercises at home, which is the part of the home exercise plan, HPE, what we call HPE. Ambulatory exercises means the walking out from the home, or with the assisted devices, or without the assisted devices. It depends on the patient's condition and as well as the demand. If the balance is good, if the patient's balance is good, there is no need to advise any assistive device like the walker, cane, crutches, or any support from any wall, or this kind of things. So ambulatory exercises or ambulation. So ask the patient to go out, like the walking, jogging, running, swimming. But again, it completely depends on you and your patient, that in what condition patient is in, or patient is able to perform or not, the exercises that you are thinking or that you are going to plan for that. Now the phase 4 is the again ambulatory phase, or the phase in which patient can perform now the some further vigorous exercises or more vigorous exercises other than just simply walking, jogging or running. After that, now the gymnastic activity or gymnasium activity. For example, now the treadmill, cycling, bicycling, now the heavy weight lifting, type of resisted exercises, heavy weight lifting, and some yoga as well, some crutches, and some other whole generalized body exercises which are very high energy demanding. So ask the patient to perform that. So in the phase 4, now the patient is in phase 4. If the patient is in phase 4, which means that he or she is near to the normal, as he was entered in the hospital before the surgery or before any disease. So in phase 4, rehabilitation or the process or the procedure of rehabilitation has completed. In the phase 4, what are the goals of the phase 4? Continued improvement, of course, the general fitness and the maintenance of the fitness, improvement of the fitness, and again the maintenance of the fitness is very important. Like, we do exercise for a few days and for a few months after cessation of exercise. Now after 2 weeks or 3 weeks we will be at the same stage from where we had started. So this is not the thing, or this is not the way. So the improvement and then maintenance is important. So in phase 4, improvement as well as the maintenance of the fitness will be considered. So unsupervised exercises program, now there is no need, patient can perform independently if patient is now is near to normal, without any limitation, without any fatigue, without any discomfort or any abnormal sensations or feeling. Now the self exercise, patient now perform self exercises without any supervision. As I told you earlier, long term behavioral modifications are also the goal of the exercise or the rehabilitation part, phase 4. Behavioral modifications, like if the patient is so aggressive, or if again a patient is not taking so much healthy, not is in the healthy lifestyle. So these are the some problems that in phase 4 we can face with the patient. So there are some sessions of counseling are needed for those patients to change the behavior, or for the healthy behavior. Now summary, cardiac rehabilitation, we have done the cardiac rehabilitation. That cardiac rehabilitation this is the summary or the overview. Cardiac rehabilitation, our goal is from the bed to take patient into the community, from the lightest exercises to the heaviest exercises, and from the less fitness or least fitness to the greatest fitness. This is the again ideology behind the cardiac rehabilitation. Goals of the cardiac rehabilitation, again, what is the cardiac rehabilitation? Multidisciplinary approach, and all the components and the parts and the goal as I described. So benefits of the exercises: patient can recover early without the heavy burden on their pockets, or as well as in the hospital. Indication and contraindications, I told you, indications and contraindications that should be considered before prescription of exercises, which are very important for the recovery and as well as deterioration too. So assessment and the pre-enrollment workup, which is again important, because assessment give you the idea what type of exercises and what level of exercise you have to prescribe. Program structure, yes, we have discussed that rehabilitation program consists on phase 1 to phase 4, means from the early bed exercises to the community exercises, implementation of the program, and the assessment of the outcome. So these all are the points that we have discussed, and it was all about the cardiac rehabilitation. Now cardiac rehabilitation, in which If you have any question or any query or any relevant problem related, any relevant problem, you can ask in the comment. And as well as this whole lecture was prepared by the physical rehabilitation of Philip 1. I will share you this book, but if you have any question or query, so feel free to ask in the comment box or in the comment section. Okay class, thank you so much.